So, Dr. Gaurav sir, can you share your screen?
Yeah.
हाँ दे दो.
So I think everybody is able to see this these cine images. Are we?
Yes, yes. Gaurav.
So this is a 60. This is a 61-year-old non-diabetic non-smoker hypertensive male who had an episode of unstable angina 6 months back. Later, he was scheduled for angiogram in outer center when the PTCA was attempted to right system. RCA is 100% occluded. We can see the retrograde filling from the left system, and there that center wire was crossed, probably filter XT, and the balloon was not crossing, so they deferred the process. So they came here all the way to Raipur and for the further procedure. So this is the left angiogram. We can see the retrograde filling of RCA up till the crux, and we can see another lesion in proximal to just prior proximal to crux, and then some filling in the mid segment, followed by complete occlusion. This is a right coronary artery angiogram. So we can see right spot in the mid RCA. Filling is done by some homocoronary channels and followed by a lesion here in crux, and uh, so in the other center wire was crossed in some segment, some artery, and the balloon was not crossed. So straight away we went with the Corsair and filter XT wire first. Although filter XT was unable to sooner the filter XT was unable to cross, so we exchanged to pilot 150 here. So problem here is we have a lot of small arterial segments in the distal cap. So wire was going into the various channels and not providing support. So we put an anchor in the this another branch and put an anchor of 2.5 into 10. So we will be able to cross some Corsair while negotiating wire. So it provided ample amount of support to us. But again, the wire was not going into the proper channel. It was going into some other artery, and expectant RCA distal segment was not being crossed. We can see this wire is some way out of the lumen of RCA. So, in spite of all of our efforts, most of the time wire was not going into the proper lumen because of the multiple branches here in the distal cap, which were not allowing us to go into the proper lumen. Although with the help of we were able to negotiate Corsair to distal segment, but again, since wire was not in the lumen, so we wouldn't be able to cross it further. So wire was changed to Gayatri now. We were hoping some distal cap is not penetrable, so might be allowing a path of least resistance and wire going to the other branches. So Gayatri is a good wire to puncture some distal cap. So we took Gayatri. In spite of that, Gayatri was not able to negotiate the true lumen. So it was a lateral view later, which actually helps us to see that we are going into the multiple channels rather than the true lumen of the RCA. Because now is anchor balloon and anchor wire was not creating hindrance in the view, so we decided to cross the wire first, later look for support. Again, with all the efforts, wire is going into the some other branches. Although not going out, no subintimal dissection were not seen. We were taking although retrograde shots only, no intergrade shots were taken in fear of some dissection might have happened, but they were not visible yet. So see, this is spot. Here there are multiple arteries which are creating actually difficult to see which artery we need to go. So a lot of changing of wires. Again, pilot 200 was taken. And this is lateral view when we decided that this is the segment we need to go. And there are small branches again which were not allowing us to go into distal most part. So this is when we cross the distal segment in the lateral view, which helped us. But again, the wire was going to the other branch behind that point. So we are looking as it's a distal RCA what we are going, but retrograde short confirmed this is not the distal RCA. It's some other branches again we have landed into. So after an hour or two of negotiation, after this point of time, we were able to cross and via Gayatri again with puncture. Let me see the slide again where we crossed with Gayatri. This is straight puncture. Yeah. So the Gayatri finally helped us to cross the distal segment, distal cap. And there was some resistance here offered as well, but we're comfortable to park into distal PLV, sorry, PDA. Now there was again a tight lumen, so we had to put anchor balloon and anchor wire again here. So we were able to drill the Corsair with the support of this. We drilled the Corsair with the support of anchor balloon, and then only balloon was able to cross. We exchanged it though first. And the dilatation with 2.550 2 into 15 balloon. So this is the integrate filling from integrating into RCA. So plan was to go ahead, go across PDA in PLV and start standing. So anchor balloon was here all the time because support was not sufficient enough and there was a tight occlusions creating some problems. Exchange to cyan blue, already exchanging cyan to cyan blue. So rest of the procedure was standard. Put 3 stents. First was 2.75. Then second was 3. Before deploying the stent, obviously we remove the anchor. And the most proximal stent was of 3.5 size. In spite of dilating it through by 3.5 at 14 atmosphere, and flaring it well, because it was an axial location, we need to flare it from the both ways. Even after post dilatation of this image, IVUS shows that proximal part and mid to proximal part was underexpanded. So we had to dilate it with again 4 into 12 balloon. Yeah, this is a 4 into 12 balloon, and flaring it again, and this is the final shot. This is the final result we achieved. So probably, in my opinion, in the earlier center, the wire was not going to the true lumen. That the balloon was unable to cross. And with the IVUS support, we were able to achieve the proper optimization of the proximal strut as well. So this is the final result. Yeah, this is all from my side today. Thanks. Back to you again, Rahul.
Thanks, sir.
Actually, I think osteoproximal was normal in this.
No, sir. Earlier we of opinion the osteoproximal was normal, but when we implanted 3 stent, the the mismatch was obviously seen in that image. So we put 3.5 from osteoids.
Suppose guiding, if you can take AL also in this cases if it is not support you are
Yeah,
taking
definitely, sir. AL is a good support, but with the help of
osteom, I
anchor
think,
and all,
but even
it's
showing RCA image, outside image, what you saw, probably osteom. I don't know actually, but whatever images you send, it is osteoproximal is normal. So in this case, I think probably AL is a good choice. Anchoring is also the technique is there, but
yep.
you are putting three stands. Good. Initially, actually, why I am telling you, I did a same case actually 1 year back. Costume was no, a little bit normal. So we land in a very. Finally, what happened? Perforation in the distal part. I am telling you because of the multiple time attempts and not able to proper anchoring the side branches. Okay. Because I have faced a lot of problem 1 year back. Similar type of cases, RCO CTA with distal cross region was there and everything was normal. Finally, last we saw that there is a compression in the distance. Similar cases, exactly. Finally, we did, but unfortunately, a patient survived when there was no coil in my lab. So finally, we did in with BMW wire, we put a coil, many things like that. The result was excellent actually. But I am telling you, third stent was necessary or not, just you know better actually. Whatever I am seeing in the osteoproximal lesion,
Yes,
Decision only when we see the three stent was expanding very well and there was some disease left in the proximal area. All the good efforts may go into vain if there is some osteo left with disease. So we decided to go across and across. And
because there are three standard chances of distance in the long term result is totally
definitely, sir, that is a thought of school of thought, but this is a standard procedure now in most of the labs. When we have a diffuse disease in RCA,
from the ostium to
we
the
have to save the ostia and the distal branches as well simultaneously. We cannot keep something diseased portion left out there to for restenosis and normal segment. So with the advent of new DAPT,
I was guided you
restenosis
did
and stenosis is very much rare nowadays. So I think no
what
fear
was that?
putting stenosis. With the advent of new DPT, we hardly encounter and statin all. We hardly encounter any stent thrombosis and stenosis nowadays, sir. It was old idea, I think.
Instant
I think you
thrombosis.
have a very good result. Can you hear me, Gaurav?
Yes, sir. Sir,
Hello.
you audible,
Yeah.
sir.
So I mean, this case is actually very good example to show the need of to persist and to think to continue thinking about the different strategy to cross the region. So you did very well actually, and
Sir,
you
thank you.
persisted and you changed your strategy by changing the wire. So it's a good case or a good case actually you presented. I was just looking at the angio, the first angio. The collateral is actually the left side collateral is filling the RCA, and
Sir,
there is actually bidirectional flow in the distal RCA.
sir.
That tells you there might be some antegrade flow from the RCA to that segment. So
Yes,
I'm
sir.
just thinking whether
That's true,
it
sir.
was a total occlusion or it has some antegrade flow through the lumen. It is a
Sir,
totally occluded
there was some
according to the
integrate
bridging
flow.
collateral.
Even you can appreciate in next angiogram, there was some integrate flow. And there was some integrate flow though, but that was through the lumen or through the homochondrial collator. That is difficult to say because
Yeah,
the
yeah,
area there, the ambiguous area, is quite difficult to negotiate again, and there are multiple branches across it.
right. So you're actually entering into the different branches. So
So
what
the
I'm
distal
thinking
cap
actually,
is
if you
more
would have tried,
troublesome than the proximal cap branches, sir.
right, right. So I mean, if there is some antegrade flow, and you might have tried the whisper wire also. I mean,
Sir,
goes
I
into the
first started I started with filter extreme only, and that because of that didn't cross through the channel, that didn't convey through the channel. So I was of opinion that it might not cross with the whisper again. So straight away plan was to stick to the escalate the wire rather than escalating them, sir. And
Yeah.
again, one thing is I should add one more thing. Even after implantation of 3.5 stent with IVUS, after IVUS was showing under expansion, the lumen was a 4. So what sir is saying that disease was not there. It was probably a diffuse disease which we were able to uh, see on IVUS. So
And if you
last
see, if
images, last
I was,
image.
then
So
it is definitely better. I was,
yes, sir.
when,
That is why
uh,
we final post dilatation was done with 4 into 12 because in spite of after even after 3.5 the stent was looking very well. But to our
Hmm.
to contrast our opinion, I
Right.
was saying no. You need to dilate more.
Yeah, definitely. I was really going to help in this case because there are multiple stents. So there is long stents, multiple stents. There you don't
Definitely
want to
need of post
under
dilation is
deploy.
yes. Yes,
Yeah,
sir.
yeah. Good case. Excellent. Very good.
that's why
Thank you, sir.
in some center, na, they are doing all left cases without IVUS. Many centers like Seoul, South Korea, they are without IVUS, they are not doing any left. Park Center, without their recommendation is only, so definitely result will better when you will use IVUS. So optimization will be definitely better. There is no doubt.
Sure.
Whatever you see, the 3.5 stand is good, but you see that you do IVUS, then it requires 4 into 12 well. Then definitely long-term result and distances will be naturally less.
Okay.
Good case actually, nice case.
Thank you, sir.
That's it. What happened
What
now?
do you?
Cost of the stent is less, the patient can afford. When the
Yes,
stent
sir,
cost,
that's true. That is one of the advantage to the our generation's cardiology. We can implant multiple stents. We can negotiate the tougher lesions as well now with a bit of
uh,
multiple
this one,
stents advantage.
just imagine 1.2 into 3 stents, it cost 3.6. So it was difficult
So,
initially. That's good. Jogesh, you can present the fine. Last I will show you one case by IVL actually just now, few days back I did it, and I will show one simple case, but it was not able to cross in the L6. I'm not able to cross the stent in L6, so I have to use IVL. I will show one.
Hello.
Can you move to
Hello.
next? Dr. Jogesh, can you share this case?
Yeah. My laptop. I am not able to connect it with the laptop, so I will change it with my mobile cam only. So, is it visible?
Yes,
Is it
sir.
visible?
Yes, sir.
So, a 50-year-old male suffered from the severe retrosternal chest pain 10 days back and was having a recurrent chest pain for 10 to 15 minutes. He was a tobacco chewer, the smoker. Patient was an ex-alcoholic and the known case of hypertension, but non-diabetic. The ECG showed the QS complex in the 2-3 AVF and the echo was as suggestive. EF was 42% with the mild MR. So the diagnosis was the CAD, inferior wall MI with the late presentation and with the post-MI angina. So patient was planned for the CAG. So this was his CAG angiography. We can see the left system as well as diseased. The LAD was diseased. The diagonal D1 was diseased. RAMS was having a lesion, and LCX non-dominant system was also having a lesion. So, and the RCA was 100% occluded. So the plan was to revascularize, but looking at the situation and the post-MI angina situation, so the patient was advised the bypass could have been done as the patient has already passed the acute phase period, but was having a post-MI angina, but the patient denied for it. So we went for a plasty, starting with the RCA first, as it was totally occluded. So the initially with the BMW wire, we are not able to negotiate. So we put down a filter FC wire, and it reached to the PLV easily. So after that, we did the multiple dilatation with a 2.5 into 12 balloon multiple times. But still, we were not able to receive a good result. So we planned for the thrombosection extensive thrombosection was done, because we are not able to find out where we have to put the stent actually. You can see that the thrombus is present since from the ostium to the distal RCA, including the PLV part. So if we have to go for it, as Bhanja sir told that we have to put 3 or 4 stents in the RCA only. And so we thought to make more of the thrombus section so that we can put a lesser stent. After the thrombus section, we can find a better result, and the thrombus was still there, but yes, to a lesser extent, and we can point out the 2 points where we have to stent. But I was of the opinion first we should put a proximal stent so that we, if required, maybe the distal thrombus we will have a less of the presentation, so we will have to put a smaller stent distally. So we put the proximal stent, we positioned it from the proximal part. We spared the ostium as it was having a good reflux. So the stent was positioned in the proximal RCA, sparing the ostium, and stent was deployed. Post deployment, the check shoot was showing a lesion in the mid distal part with a thrombus part. So we have to take a longer stent for the 3 into 33 mm, and the final shoot was showing a good revascularization, and a part of with the small thrombus parts which were there, and we put the this tirofiban intracoronary and planned for giving tirofiban infusion later on. But we have to treat the this left system as well. So we plan to revascularize, we do the complete revascularization in the same setting. So the left coronary angiography was done, the L6 wiring was done, and with the pre-dilatation with the 2.5, the same balloon, and we put the stent of 2.75 into 28 mm, and did a post-dilatation with the 2.75, and it was the final check shoot. In the same time, we did the IFR of the ramus part, and it was showing, we did the IFR, not the FFR, but it was showing a IFR value of 0.92. So we left the ramus. As already we are planning to make a LED diagonal bifurcation stenting. So that was a thing in our mind. So what I planned was to stent this LED in the diagonal, so that we will be having right now also the 5 stents right now. So LED diagonal were wired, did the pre-dilatation of the diagonal with the same balloon 2.512, and the dilatation of LED was also done. Now LED stent of 3 into 28 mm was parked, looking at the situation at the diagonal, and we are confirming the size of it. The 2.75 into 18 mm diagonal stent was parked in the ostium in allocranial view. It was deployed, and the LED stent was positioned accordingly, and it was done a mini crash of the diagonal stent. So after this check shoot, we saw the stretches crushing was crushed at the ostium. So rewiring was done of the diagonal, and the stud dilatation was done initially with the 2 into 10 mm balloon. Then final kissing was performed with the 3 into 12 balloon with the 2 into
Yogesh sir, are you back again? Hello. Hello.
Hello. Uh,
Rahul?
Yes, sir.
Hello?
Dr. Yogesh,
Um,
Dr. Yogesh, are you there?
Yes. Yes, yes. Where it was disconnected, I want to know that.
After kissing.
Hello? Hello?
Yeah, Yogesh, sir, am I audible to you?
Yes, you are audible.
So after kissing,
Hello?
your slides were not moving.
After FKBI, na?
Yes, yes.
Hello?
Hello, Yogesh, sir, am I audible? Hello. I think sir got disconnected again. We'll just wait for 5 minutes, sir, for sir to rejoin. Hello, Yogesh, sir, am I
Hello?
audible to you?
Ah, yes, 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 Rahul, you are audible to me.
So, sir, after that kissing, your slides were not moving.
Okay. So, this was the FKBI, which I did. And after that, we took the stent boost and optimized the proximal part of the stent. And this was the final result of LAD diagonal revascularization with the mini clutch bifurcation stenting. We can see the good flowing LCX, the LAD D1, and RCA we have revascularized. And after that, we put the patient on the tirofiban for the next.
I think there is some network issues. Dr. Rajiv, sir, can you share your screen? Hello.
Hello, Yogesh sir, are you there?
Yes.
So can you
Yes,
share
I
the
am.
final thought? I think you are facing network
Yes, yes,
issues.
yes.
Can you move on to
Yes.
Dr. Rajiv sir's presentation?
Okay.
Dr. Rajiv sir and Dr. Sunil sir, any comments on this?
My slide is visible. Huh?
Yes, sir, your slide is visible.
Okay. Hello, hello. Sunil, are you there?
Yes, yes, I'm
Gaurav?
here. lot of noise was coming actually.
I am here only.
Yes, sir. Actually, this is a case presented to me with basically, hello, angina effort class 3. So you can female patients, 68 year and diabetic. You see that what is the angiogram actually? Just I am seeing the L6 and you can see the LAD. RCA is basically non-dominant and 100% occluded from the proximal part. Distal flow was very minimal. So actually, I asked for CABG. They refused. They went home. The next day night, they admitted with acute LVF. I have stabilized the patients. Again, asked for you do CABG, but they refused. I will not do CABG. So then I thought I will try for angioplasty to L6 and LAD. And you can, I took the patients and by femoral approach, I crossed the OR was crossed easily. And I pre-dilate the lesion very nicely with 2 balloon, 2.5 balloon, even up to 2.7 balloon, NC balloon. You can see the proximal calcium. At that time, I have no rotor, IVL, nothing was there. I tried my level best, but I am not able to cross the proximal lesion putting the stand. But if you see that balloon dilatation was good, that we can cross the stand. Even you see that left main distal is not good. After that, I tried stand my again post dilate to 2.753 balloon was not able to cross. Then I leave with this much, and the patient was discharged. IVL was not in my lab. Again, patient presented off and on angina. We just 10 days back, again, patient was admitted with similar episode. Then I took the patient to lab. You can see. And you see again similar. Bluetooth mode. This time I have my IVL in my hand, and you see this is the IVL and distal. I did, but unfortunately, what happens once during the IVL, patient has bradycardia and patient hypotension. So immediately I pull the balloon. Then after that, I am not able to cross the balloon even to the distal part. So I did to the IVL to the proximal part, and after you see this is the proximal part I did. This is the final result, and I thought I will manage to cross this stand. But after multiple attempts, I am not able to cross the stand from the proximal. Similar episodes I was having the problem 15 days back also, now having some similar problem. Then what I did, I initially did the body OR. Then after that, I am able to cross this lesion. And in between, I have what I during the IBL balloon was punctured. I will tell you the details after putting the stent. I will tell you details. And you see, this was. You will see the stent has inflated very nicely. By then, similar, I post dilated the stent, and nothing was. After that, then LED was stented, and this is the final result of LED L6. What happens actually? Why I solved this case during IBL also, the balloon was punctured, and it was not known to me. When I pulled the balloon, I think Gaurav's case, 2-3 case you did IBL.
Yes, sir. 5-6 cases I have done, sir.
But have you seen this type of problem in your lab? This
Sir,
IBL?
IVL balloon profile is always a problem. That is why they have a very that we need to predilate it optimally before the IVL uses.
Yeah, I
And
have seen, I already you saw the how I have pre-dilated the balloon in 15 days
so
back.
yeah, profile the balloon is not very good quality, sir. It's I have 2 ruptured balloon in my cath lab as well.
So actually, why
After
this?
4-5 pulses were given, I was planning to do pulsation to other artery as well, but I was not able to give pulses because balloon was ruptured. So profile of a balloon is a problem. That why they are coming with IVL 2 as well, with the inner and outer lumen. Probably that will help us to tackle these kind of problems, sir.
Actually, why I want to show this case is because this patient was only LED was not that much critical that I could not cross the balloon. Nothing was there, but L6 was so calcified and the ostium it was not possible to cross the balloon on the initial phase. So I thought I will do the small stent to 2 small stents, distal and proximal. But I have tried a lot, but I could not cross the stent in the this osteoproximal lesion. And only after IVL and near about 60 distal, I have to use twice, and proximal I was thrice. So you see, 60 I have spent it in L6. After that, I think I have probably punctured the balloon. But fortunately, I am able to cross the stent by using body air. As patient in between near about 30 minutes I have to spend in the lab, and patient was 3 to 4 times patient on hypertension, patient was bradycardia, and finally I succeed this case. But thus I want to show that because of your experience, I am asking whether you have how many times you have faced this type of problem in your normal routine cases in when you used IBL, because it was my second case. First case I have any problem. This type of lesion in calcified lesion, whether you are facing this type of problem with puncturing the balloon, and because you didn't know whether you have punctured the balloon or not, and what is the consequences if you have punctured the balloon in IBL balloon.
I was aware of the IVL rupture only after a balloon was coming out. I have not aware when in what you can be done when you give a shock in a punctured balloon. But again, when you dilate it to 4, you can very well realize that balloon is punctured. So no issues. We can not give shocks. Sir, in your case, sir, there was definitely some eccentric calcium when you were dilating balloon. There can some dog boning was quite visible. So it was a very good case for IVL, sir. It was probably the ideal one for IVL, because routine LCX is not a very good option because it's some curvature which can cause wire bias. So
Actually,
it's great
exactly.
case, sir. Yes, sir.
Actually, I could succeed, but it was too tough because twice I have the patient back into the lab, and because you see the ostium of the left man, basically the ostium and the distal part, it was not that much healthy, and patient was not willing for the CABG. Already L6, RCA was non-dominant, and it was near about CTO, a small vessel. So it was a
Sir.
difficult case to handle this thing. So I thought I will equalize IBL, then probably I may succeed.
Sir.
But
And since it was a dominant LCX, that episode of bradycardia and hypertension is very well explained. Yes,
And
sir.
probably my question is whether this was not because of punctured balloon, or it is totally because of whether I am using this multiple times balloon, this hypertension or bradycardia was happening. Just I want to confirm from
Sir,
you because you have.
most of the time when artery gives it way, there are some VPCs we used to see in our lab as well. But if it was a dominant LCX, so it can very well explain the occurrence of bradycardia and hypertension in your case, sir.
Because it is a flowing vessel was there.
Yes, sir, but maybe it do occur, sir, many times in our lab as well. Some VPCs, and after artery gives it way, some VPCs, some brady episode do occur mostly in even in a flowing vessel in our lab. And since it was a dominant LCX, that explains hypertension as well.
Sunil, have you used IBL in your lab?
I think Sunil sir got disconnected.
Okay. You have your IBL in your lab, Gaurav?
Sir, we have that since Typhoid IBL is available with transfer most of the time, so we can call on the same day basis as well. 1 hour or 2 hour, they will be availing it.
That is a good thing. If even you are not, that is a good thing. You can
So,
easily whenever you.
they are having it here most of the time. So we have on sales. We do have a SP or a OP and NC balloon. We have LBO SP balloon with us, but IBL we used to have on call basis only because it's a costly thing to call for, sir.
And other balloons are available in our lab because if you will not able to cross this stand, then that is not. There is no use of balloon. I have tried.
Definitely, it's a good choice to use IBL in your case, sir. It was a good choice to use
Because I
IBL.
have already used 3-4 balloons in this case. After
Oh.
that, also you saw how the stands was crossing. It was not able to totally. I'm not probably the proximal jump of calcium was very high.
Yes, sir.
Yeah.
Sir.
Thank you. Rahul, Jogesh will come.
Sir, Dr. Jogesh is facing some issues, network issues. I think he is traveling. He is on Bilaspur station only, sir.
Acha, okay. Okay.
So I think there is no more presentation now.
Jogesh
So
case
I would
was
like-
also a good example of complete revascularization strategy.
But in Sam sitting, it is too difficult. All this
Yes, sir.
thrombotic lesion.
That is something to make a call for whether you can do. I prefer to do in a different setting.
Yeah, definitely. Even a thrombotic lesion, if you do multiple stenting, patient
because
there is
MI is MI is itself a state of thrombotic milieu. It can cause
highly thrombotic actually. RCO are highly thrombotic, and even after balloon, he is doing a thrombosuction. It is also here and with a good result. That is good. But
Yes,
usually, preferably before ballooning, if you do a thrombosuction result, maybe I think it is better.
sir.
And doing some multiple time as ballooning multiple OR in multiple vessels in this type of scenario, I think it is lucky to have good result in this.
Yes, sir.
I should have preferred probably. What is your opinion? In same setting you will do or?
So in such cases, always in MI cases, I do prefer staged PCI because the milieu of entire body is very thrombotic. It can cause no flow, slow flow phenomena. Although
Exactly.
definitely
Exactly.
we should be staging our procedure. If it is a stable patient, chronic stable angina patient, we can definitely ad hoc planning. Can be done. But in
I
MI
never
cases,
do. I never do. We are doing a lot of primary, but I
MI
never
cases,
do
MI
single.
cases should be staged only.
I do all cases in stage.
Yes, sir.
All cases.
Sir.
Okay, thank you, Rahul. And thank you, Gaurav. Goodbye.
I would like to thank all our speakers, Dr. Gaurav sir, Dr. Jogesh sir, Dr. Bhanja sir, and Dr. Sunil sir for joining the webinar on Dhanteras. Wishing you all very happy and prosperous and safe Diwali ahead. Thank you very much, everyone. Thank you.
Thank you.
Thank you, sir.
Thank you, Gaurav.